This first talk we're gonna address the early diagnosis tools and strategies we do, and also talking a little bit about screening. I have no conflicts of interest related to this talk. And as you know, prostate cancer is the most common cancer and the second most lethal cancer diagnosed in men. It's estimated over 164,000 new cases and almost 30,000 new deaths in 2018 alone. As you all know, probability of developing prostate cancer increases with age, and it's estimated that 1 out of 9 men will be at risk over the course of their lives of having a diagnosis of a prostate cancer. We know the African American men, they are at risk not only for a higher chance of having cancer, but also more aggressive cancer. So as you can see here, this first table is showing the incidence, how it's elevated on African Americans, and also how the death rates, the mortality is also elevated in that population. So when we talk about screening, what's that involved? So it's a complete visit when you have to go over all the details in terms of a history and physical exam, including a rectal exam. We have to make a very thorough assessment of the comorbid conditions, and then try to make an estimation of life expectancy. This is challenging, and there are some tools, there are some nomograms and different ways to calculate this, but there's always limitations on how well can we predict someone life expectancy. The government tables include just very, very crude age and a race data, but we all feel that we have a good sense of, someone is in good health or not so good health. And this is important for the decision making on how we're going to manage this patient's diagnosis. So after we make those assessments, we have to discuss individual risks and, of course, define what are the personal goals for the patient care and what patient want, after having diagnosis, what's their intention, if they want to treat it or not, what are their overall expectations from the care. And, of course, that discussion is going to include the indication for the PSA, what are the consequences of having a PSA test, what happens if the test is positive, risks and benefits, what that will lead in terms of further tests and treatment. So, and why has been so much controversy about screening? So, especially in the US, the PSA, mostly from the primary physicians, not so much from urologists, but has been analyzed as a just binary test. It's either positive or negative using the regular cutoff of 4. This cutoff has been proposed to be dropped to 2.5. But if you look that way, you're going to be biopsying a lot of men unnecessarily. And the second point, so this leads to overdiagnosis. And the second point after that is after having a biopsy and a diagnosis of prostate cancer, then comes the dilemma. This cancer needs to be treated. And if you don't analyze this carefully and start to treating everyone, this will lead to over-treatment. So surgery and radiation therapy with all the side effects done unnecessarily. So task force start to send some publications and statements in 2008, updated in 2012, and at that time they had a recommendation D, meaning they were against PSA-based screening. That generated a lot of discussion, a lot of controversy, because we all feel the PSA is valuable and helps in the detection and screening of prostate cancer. Is a very important tool. I'm going to show some data, but then this is just to show you how this grade of recommendations go, and as you can see, D is the lowest possible. It's just completely against. The test should not be performed, and that was based on the largely true randomized trials. One is the European trial DRSPC, which had a longer follow-up published afterwards with 11 years follow-up, and then also the American trial, the PLCO. And these trials that showed some benefit on screen, the PLCO was not positive, and based on other meta-analysis and other studies that were not so well developed, they come up with this recommendation. So there's several critiques we can do both to the trials and also to the task force recommendations. It's not the focus on this talk, But I think the conclusions were a little preliminary. They didn't have the full follow-up data. There's the issue about looking overall mortality in prostate cancer. These studies need to have a long follow-up, and if you look only 10 years, that might not be enough to assess, the real benefit of having a screening strategy. Poll data, the statistical issues in comparing confidence intervals, and then also there's overestimation in terms of risks of biopsy and the side effects of treatment. So several critiques in there. The subsets of the European study were also published, and they're also shown to be very positive in terms of benefits of screening. And then all the urological societies, AUA, SUO, the NCCN guidelines, the ACS, ASCO, all the societies, came up with recommendations. And the bottom line is, we all agree that there is over-diagnosis and over treatment, but at the end of the day, PSA is not supposed to be discarded. We just need to take that judiciously and do a discussion with the patient, weigh benefits and risks, and try to individualize these risks as much as possible. So with that regard, the discussion has been going on for 6 years since that first 2012 grade D recommendation, and then recently this year we got a new updated recommendation, and the task force downgraded this to a grade C recommendation, meaning they're not against anymore, but that the decision needs to be discussed with the patient, should be considered, and that was made for the patients between 55 and 69 years of age. That's the age range in those randomized trials. For the patients older than that, 70 years old or older, the recommendation was 2D. But there's very little data on patients older than that age. So this is better. It's not ideal, but it's at least it's moving in the right direction. So at the end of the day, is PSA good or bad? And if you look at this data, you can see the trend, and this is the number of deaths over time. And if you see the blue line, how this was projecting, they're supposed to follow the red line projection here. And then what happened is around the 90s, we had a deflection on the curve. And the only thing that came up on prostate cancer management, or only thing that can happen to alter the biology of the disease, was actually the PSA test. That's exactly the time when the test was developed, was put in practice, and altered the way we're both diagnosing and then starting treating these patients. So there was one single factor there that was responsible for this change. And then if you look at this graphic on the left, what you're seeing is the incidence of cancer over time, and comparing different cancers. Prostate cancer is this brown line here, and again, over the 90s, there's this jump on the curve, and again, there's no biological factor to explain such increase in incidence of a cancer. What happened was we started using a test that is very sensitive to detect this tumor. So we actually got the incidence to the correct level. And then if you look at the mortality curves after that time, because these patients are being more diagnosed and more treated, then mortality also drops. So screening has shown to decrease the age of diagnosis in about 10 years. There's obviously overdiagnosis and overtreatment, but that's we're being aware, and we need to just reduce unnecessary biopsies, and a lot of work has been done that way. Active surveillance is one way to mitigate those risks. When identify cancer, not every single cancer needs to be treated. There's cancers that are indolent and they're not aggressive, and those patients don't need to be treated immediately. So that's a perfect way to mitigate the overtreatment risks. And at the end of the day, the bottom line message is that we need to individualize the risks and a personalized approach in these patients. So how do we do that? So we've been doing this for many years. Since PSA came up, we've soon realized that that test had very strong limitations, because it was not specific for cancer. It's specific for the prostate, but it's not specific for cancer. So we've been using different cutoffs. We've been using the percent free of PSA. We've been using age adjusted of the total PSA, and are trying to use that to drive our decisions. We're also look at the baseline PSA that is done when a younger age, patients between 45 and 50 years of age, and if that's below 1 or 1.5, is supposed to be the median for the Caucasian population at that age. we know these patients have a very, very low risk of developing prostate cancer down the road, so that also can drive our decision of how often we're going to offer this test. We use other things. For example, we adjust for density. It's an obvious correlation with the prostate size. So large prostate tends to produce more PSA. So if you can adjust the PSA by the volume and I use this cutoff, we're gonna be more specific in terms of recommending biopsy for those who need. PSA kinetics. So in the look of velocity, there's different ways to calculate this. Probably the most accepted is using 3 measurements with a reasonably long interval, and then depending on the baseline of the total PSA, we look at different cutoffs. But that also can give us a clue if it is rapidly increase in the PSA levels are more likely to be from benign infection or something, or cancer. And we look at the known risk factors, and the most common risk factors are listed here. So family history is the most important, not only for prostate cancer but also for breast cancer, and we know there's a strong correlation with the presence of a BRCA1, BRCA2 genes, especially the BRCA2. Race, as I mentioned before, and age. As patient age, the chance of developing cancer becomes more common. What else? We've been using parting tables, nomograms, a lot of our risk calculators, and this is just a very limited small sample. There's a lot of calculators and nomograms out there that can help us to stratify risks and try to individualize and try to be more specific in terms of who are at a higher risk of developing cancer. And now we have even more tests that we use. So I'll put first of all the MRI. So multiparametric MRI has developed enormously in the past few years, and that not only allows us to now identify cancers, localize them in the gland, but also we can target those lesions. So we can use that image now to direct our needles and get a more precise and more accurate biopsy. That also can be used for treatment. If you're talking about focal therapy, that can be guided by the MRI imaging. So this is all in development and getting better and better every day. We have new molecular tests, both in the urine and blood. We can also test tissues for patients who had previous biopsies. They were negative. So there's now a lot of tests approved and commercially available that can help us decide and help us stratify risks of the patients who need more biopsies or need to go further in the diagnostic pathway. And also PET agents. So even that is getting better in terms of diagnosing advanced disease, localizing disease. So we have a lot of new tools these days to help us stratify risks. So in terms of patients with normal PSAs, with or without previous negative biopsies in the blood, I'm just going to mention very briefly here because we're going to probably talk about this later on in the subsequent talks. But for example, in the blood, we can use the PHI, the Prostate Health Index, the 4K, the 4-cadherin tests. We can use in the urine the PCA3, the Select MDX. They're both tests that are checked in the urine after a prostatic exam or a little massage. And there's the EPI, the ExoDX, the Prostate IntelliScore. That does not require a rectal exam. It's just you're looking at exomes in the urine. In the tissue, we can use the Confirm MDX that looks for methylation in 3 genes on the tissues from previous biopsies. And again, MRI, I'll include MRI as a biomarker because that's the role that MRI is taking at this place. So just to give you a couple examples, you can see some hypointense areas here correlating in the whole mount with the area where the tumor was located. You can see very well delineated, in different imaging. This was a very anterior tumor, correlates with the specimen. So MRI is being fantastic in terms of localizing disease, helping in the decision making, both for diagnosis purposes, but also for treatment purposes. And again, with all these reconstructions, ADC maps, DWI maps, I'm going to talk about this in my next talk too. You see, you don't need to be an expert, you don't need to know radiology, you don't need to understand MRI. You just take a look and say, yeah, there's something there, no question. So the other advantage is the biopsy, the fusion biopsy. We can use the MRI information to guide our needles. So here, as you can see, this is a 3-dimensional reconstruction of the prostate, and we can rotate this model, we can just look in all different perspectives, and you see where the suspicious lesion is located, and you can drive our biopsy cores and get their needles targeted to the area, so it increases the accuracy of our biopsies as well. So quick overview for the PHI, the 4K score. This is a sample of the report giving the chance of having an aggressive disease on subsequent biopsies. This is the PCA3. Again, you can play around with the cutoff, but depending if it's above or below, it indicates the risk of having a prostate cancer diagnosed on a subsequent biopsy. The PCA3 is indicated for patients with a previous negative biopsy only, not so much in those who never had a biopsy before. But anyways, it's an easy test. The Select MDX is probably the newest one, also done in the urine. Sample of the report, again, given as a likelihood of having prostate cancer upon a subsequent biopsy. And then the IntelliScore, the EPI, same thing. This does not require DRE. It looks at exomes in the urine. We can get the mRNA. This looks like 3 different genes, and then based on that expression, we have risks, and that seems to perform better than PSA alone or any other calculators looking at these ROC curves. ConfirmDX, I mentioned before, is looking at the tissue and look at every single biopsy core for methylation of those 3 genes. If you have methylation positive, that core is considered positive. So the report gives you this map showing where in the prostate that score was positive. And this is a combined on likelihood of having a positive biopsy as well. So my final slide, so how do we integrate all of this? So we don't try to avoid the word screening just because of this old controversies been going on for almost 10 years. So we don't say screening because it tends to entail that we're going to just apply a test blindly to everyone in the population and then act accordingly. So it's not what we do. What we do is more individualized risks, personalized approach. We try to assess who needs and who doesn't and have that discussion with the patient so the patient participates in the decision if they need to have PSA, if they need tests done, if they need to have a biopsy done. But anyways, after you have that decision and, for example, an elevated PSA, then the discussion about the biopsy will entail the consideration for the risk factors that I mentioned, and also all these new markers for patients who never had a biopsy before that would not include PCA3 or ConfirmMDX, but you can use MRI, you can use the urine test, you can use the blood test. Let's say patient had a biopsy. If you have a atypia or high-grade PIN, you're probably going to need to rebiopsy at different intervals. If you have cancer, you're going to treat accordingly. How about those patients who had a biopsy and come back negative, but you still have the suspicion that persisted concern for cancer? Then you can still use these markers. A couple other markers are specifically used in this space. MRI and fusion biopsy has been purported to be the best test in these locations, the sweet spot for this test. And if you had a chance to take these markers before the biopsy, you can use these markers after the biopsy. And putting this all together will give you more information towards your decision. I'll be happy to take any questions.